In this video, a surgical tip for correcting ankle malalignment during arthroscopic ankle arthrodesis is described by means of a lateral K-wire used as a joystick for controlling the talus. The patient is usually placed in the supine position under general or locoregional anesthesia with a high-tie tourniquet and with the knee slightly flexed. The skin projection of the joint line is found out by repetitive flexion-extension movements of the ankle. Skin landmarks are identified such as the tibialis anterior tendon, the medial malleolus, the extensor digitorum longus tendon, and the lateral malleolus. This allows to place the two arthroscopic portals on the joint line. After the injection of 5 to 10 cc of saline solution, a 5 mm incision corresponding to the anteromedial portal is placed. An introducer is positioned, followed by a 4 mm arthroscope. By means of transillumination, the anterolateral portal is placed through a 5 mm incision medially to the lateral malleolus and laterally to the extensor digitorum longus tendon. After the synovectomy and debridement of the anterior fibrous scar tissue, the inner of the joint is well visualized. A 4 mm bar is inserted to freshen the joint surfaces of the tibia and the talus, including both gutters, moving from anterior to posterior and vice versa. A curved curette or a microfracturing tool may be used to better expose the subchondral bone. Once the articular surfaces look like completely freshened, exchanging instruments in portals may be useful to freshen zones not accessible with the bar in the lateral portal. A fibrillar intraarticular resection is then performed according to the previously described technique with the aim of gaining a full ascension of the talus towards the tibia. At this point of the procedure, talus need to be definitely aligned in order to increase the total contact surface between the two bones and to gain a neutral alignment of the hindfoot as well. A 3 mm K-wire is introduced in the talus through the anterolateral portal under optical control from the anteromedial portal. The introduction point on the talus depends on the intraarticular deformity. In case of varus, the pin is introduced on the lateral aspect of the talar neck as anteriorly as possible. Its position on the coronal plane is parallel to the talar dome, or aiming proximal to obtain maximum reduction power. In case of a valgus intraarticular deformity, the pin is positioned as far posteriorly as allowed by the fibula. On the coronal plane, its position is also parallel to the talar dome, or aiming plantarly. The pin is progressed through the talus into the opposite cortex, taking care not to violate it, avoiding injuries to the posterior tibial neurovascular bundle. For a right-handed operator, the reduction maneuver is a combined solid derotation of the talus along with the correction of the coronal plane using a K-wire in the left hand, while at the same time pushing under the sole of the foot with the abdomen to ensure plantigrade position. The right hand serves to insert the guide pins during fixation. To stabilize the arthrodesis, two K-wires are introduced in parallel or almost parallel configuration on the medial distal aspect of the tibia. Their direction is from medial to lateral, proximal to distal, and posterior to anterior. Two cannulated compression percutaneous screws are used to fix the arthrodesis, taking care to completely insert the distal threads into the talus. The K-wire placement, drilling, and screws insertion are all performed and checked under fluoroscopy.